Thanks very much. What I'm going to talk about is summarize a little bit ventilator-induced lung injury for you. I know you're familiar with a lot of this, and I'm going to have a little focus on NAVA for the last part. Here's my conflict of interest disclosure. The main thing, of course, is I mentioned yesterday, I consult Forma K. So what I'm going to do is very briefly talk about the physical factors that lead or can lead to ventilator-induced lung injury and biotrauma. Ask in a few slides, why do we need any new approaches? We have the ARDSnet study, which shows a decrease in mortality. Isn't that sufficient? And then talk about some of the potential benefits of NAVA and conclude. So I'd like to start, actually I'd like to show this slide, this movie. This is a lung being ventilated, a rat lung being ventilated with 7 ml per kilo at different PEEP levels. And I think it gives you a feel for a couple of the mechanisms that can lead to ventilator-induced lung injury. So I'm going to start the movie. It's going to start with 0 PEEP. Then we're going to increase the PEEP, as you'll see. This is 0 PEEP. And as you can see, there's areas of atelectasis that remain. There's heterogeneity. There's parts of the lung that are inflated. The next breath, or 2 breaths, you'll see we add PEEP, at PEEP of 10 or 15. You can see now that the lung starts to become recruited. There's areas of the lung that were not recruited, are now recruited. This takes a few breaths. This area will come up next. Finally, you'll see this area becomes recruited. Now the lung looks probably overinflated, in fact. We're maintaining the high PEEP. Now go back to 0 PEEP. You see 0 PEEP. First breath, pretty good inflation, homogeneous. Next breath, you can see heterogeneous inflation again, with lungs that are parts of the lung that are collapsed, parts of the lungs that are well ventilated. So I think this is the kind of thing that happens in patients you're being ventilated. It's much more dramatic here because there's no chest wall. And with no chest wall, at end expiration, the lung completely collapsed. That doesn't happen. We have an RV. But I think you can see the heterogeneity is likely the case that occurs in patients who are being ventilated, certainly with ARDS. You can see that the lung recruits and de-recruits. That can lead to injury. You can see that there's parts of the lung that can be overinflated. So those are all possible mechanisms that can lead to ventilator-induced lung injury. And I've just summarized here the physical factors that can aggravate or lead to a lung injury. There's overdistension, volutrauma, gross barotrauma that can occur by overinflation of the lung. And simply, at low volumes, there's something we've called atelectrauma, number of mechanisms by which that can potentially lead to structural injury. And both types of injury can lead to release of mediators and biotrauma. So that's the mechanisms, if you like, the gross physical mechanisms that might lead to ventilator-induced lung injury. Well, based on some of that thinking, the ARDSnet investigators, as you know, published a landmark study in the New England Journal of Medicine in 2000, showed that mortality could be decreased with an ARDS from 40% to 31%, using a strategy, a lung protective strategy with smaller tidal volumes of 6 ml per kilo. So that's pretty good. That's a very large decrease in absolute mortality for any intervention. So is that enough? Or do we need other strategies? We have a pretty good strategy. We need other strategies. And I think the question unequivocally is yes, we need new strategy. I'm actually surprised that that study was published 12 years ago. I would have thought by now we have other strategies that are proven to be more effective. That hasn't happened yet. So this is a study by Salvatore Grasso from Italy to look at the question of whether the ARDSnet strategy could still lead to overinflation, because they tried to limit plateau pressures to 30 using small tidal volumes. So they studied 15 ARDS patients. They compared the ARDSnet strategy with a strategy based on something called the stress index. I'm not going to go into details what the stress index is, but essentially there's a parameter B. If that parameter is around 1, there's probably minimal stress. If it's much greater than 1 or much less than 1, you can have either overdistension or a collapse or reopening. So what they did was they used that strategy. They used the same ventilatory pattern as the ARDSnet, but PEEP was adjusted to minimize the stress index. And they measured mechanics and various cytokines. And here's some of the results. This is now the stress index, and you can see with the ARDSnet strategy, a number of patients had stress indices that were greater than 1.1. Suggesting overdistension. They then added PEEP, decreased PEEP, to get the stress index down around 1, between 0.9 and 1.1. And here's what happened to the total PEEP. In this case, all of these went down with a to decrease the stress index. And I'll just show you one example of their data. This is plasma IL-6 levels, just one index that you can measure relatively quickly to suggest that by going to a stress index approach and by showing that they can have a decrease in plasma levels of IL-6, suggested that this strategy likely decreased injury. The important point was that it's likely that the ARDSnet strategy is not sufficient. It actually can still lead to overdistension in some patients. So how can we minimize these detrimental consequences of mechanical ventilation? Well, there's a number of physiological approaches. I'm not going to describe these in any detail. There's imaging, perhaps with EIT, different ventilatory approaches. As you know, there's a couple of trials ongoing now with high-frequency ventilation, for example. Extracorporeal gas exchange is another approach. And I'm going to focus, just because of the topic today, just on NAVA is one possibility. And I'm just going to present data on one particular study that actually Lucas Brander was the first author on when he was in Toronto. He did a very nice job looking at NAVA and seeing whether it could lead to decreased injury. So the hypothesis, and something we've talked about today, is by letting the patient take control of the tidal volume and control of the pattern of breathing, could this limit ventilator-induced lung injury? And I think there's a pretty interesting rationale for this study. And that's the rationale is, you've heard about some of the reflexes, the vagal reflexes. There are a number of reflexes in the lung. There are rapidly adapting receptors, slowly adapting receptors, C receptors, a lot of receptors in the lung that change and limit the pattern of breathing and limit tidal volume. I think these receptors are clearly very important and are likely important during acute lung injury. Maybe that's why these patients have shallow, rapid breathing. Because if they took deeper breaths, there may be the receptors saying, whoa, I don't want to go any higher, because that might increase injury. So those receptors might be quite useful for us to target. Well, the nice thing with NAVA is that you can actually then use that information. So each patient can act as their own control on a minute by minute, breath by breath basis. So the methods we used were rabbits with tracheal acid instillation, 3 groups. Control group with a large tidal volume, we knew it caused more injury, 15 ml per kilo. 6 ml per kilo group, similar to the ARDSnet, and the NAVA group. The animals were anesthetized, ventilated. They had to have stable hemodynamics and oxygenation before proceeding, and then the animals were randomized. And induction of injury, actually randomization was later. Induction of injury was, first of all, paralyze the animals, give them hydrochloric acid. I think a pretty good model of, a clinically relevant model of acute lung injury. And then they were ventilated then for half an hour, and blood gases were measured. If the blood gases were within this range, 80 to 200, they were then randomized. If the oxygenation was much worse, we said, let's not even include those in the study because they might be too sick and will die. If it was much better, they weren't sick enough. But the randomization occurred after we looked at those numbers. So here's some of the results. This is the tidal volume, mils per kilogram, versus time on the x-axis. You can see here the 15 ml per kilo. Not surprisingly, tidal volume was 15 ml per kilo. 6 ml per kilo, the tidal volume was 6 ml per kilo. This group, I think, is the interesting group. This is the NAVA group. Because now these animals chose their own tidal volume. And you can see the initial tidal volume was around 2 ml per kilo. There might have been some impact from the paralytic agent in the first hour or so. But you can see by the end of the study, over 6 hours, tidal volume was roughly between 3 and 4 ml per kilo. So that's the tidal volume these animals chose on average. You can see that, of course, there's a standard deviation. Some had tidal volumes around 6 or so. Some had lower tidal volumes. What did that mean in terms of PEEP levels? Well, PEEP levels, you can see here, for the 15 ml per kilo, we kept relatively low. The PEEP levels were virtually the same for the NAVA and the 6 ml per kilo group. What about results? Here's PF ratio and wet to dry weight. So PF ratio, the worst group was the 15 ml per kilo. The other 2 groups, there were some differences between NAVA and 6 ml per kilo, not very much, and at the end of 6 hours, virtually identical. So in terms of oxygenation, not much different. Here's now wet to dry weight ratio. This is the dependent region in the right lower lobe. This is the non-dependent region. And as you can see that there's a compared to the control, 15 ml per kilo, highest wet to dry weight ratio, and lower with 6 ml, and lower still with NAVA. And this occurred in the dependent and non-dependent regions. Here is IL-8 levels, one of the cytokines. This is before acute lung injury, 3 hours later and 6 hours later. You can see these 15 ml per kilo had a marked increase and a decrease in both groups, roughly the same. Tendency for NAVA to be lower, but roughly the same. And the same was true of IL-8 concentration in some non-pulmonary organs, including the spleen, kidney, heart. And you can see the pattern is usually the same, that this 15 ml per kilo, clearly worse, higher levels, and the 6 ml in NAVA, similar, with most of these NAVA had a significant difference, decrease, or roughly the same. So never was a little better or the same as 6 ml per kilo. So I think what these data showed is that using NAVA, you can certainly ventilate these animals, and you can get the same or better outcomes in terms of lung injury assessed by a number of different methods compared to 6 ml per kilo. I think the key issue here from applying this to humans, however, is the hypothesis relates to the fact that you've got receptors that suggest that you might be able to, the patient can control their own tidal volume. That assumes that the patient's receptors and control are in fact intact. But what about if you have very severe injury? Maybe those receptors are injured. So I think we can't say that this is definitely going to be the case in humans. We don't know. Really, this is one of those things where I think we have to study it to see if there will be better outcomes, because some patients may do better, some patients may not do better, depending on whether this innate feedback is better. It's interesting, we talked about, this is now sort of spontaneous breathing that's assisted, but the other approach we heard about was, complete opposite approach, if you like, neuromuscular blockade, controlled ventilation for the first 48 hours. This was a study by, as you know, by Papazian, showed this decrease in mortality. Interestingly, the decrease in the Kaplan-Meier curve, the separation occurred at about 16 days. You could talk about why that might be. And I wrote an editorial on that, and I thought that one of the mechanisms might be actually decreasing ventilator-induced lung injury. So one approach, ironically, might be potentially to paralyze the patients, to get rid of, you control the ventilation completely. The other approach, maybe to minimize ventilator-induced lung injury, might be to use NAVA and have them breathe on their own. Which of these two is the right way? Or maybe it's a graded, maybe for the first 24 or 48 hours, you paralyze them, take control in these really, really sick patients. I think that might be the right thing to do. And later switch to something with spontaneous breathing. We don't know for sure. So in summary, there are a number of different forms of ventilator-induced lung injury. I didn't have time to discuss these in any detail in 15 minutes. I think the ARDSnet is still the gold standard until we see something better, but it's certainly not perfect. We definitely need a better approach to ventilate patients. I think still some of the mortality that we see in ARDS patients is still occurring from the ventilation. It's still iatrogenic. Number of approaches that are possible. NAVA, I think, has a potential because it allows patients to control their own tidal volume, and as long as the appropriate feedback receptors, feedback loops are in place, I think would be a very good way to try and minimize ventilator-induced lung injury. Thank you very much. Be happy to take some questions.